And we're back. I'm your host, BKP, and it's time for Ask the Doc. We want to thank Northside Hospital Cancer Institute, the Georgia Cancer Specialist, for sponsoring this segment. Dr. Whaley, how are you today?
Great, yourself?
I'm great. I was a little worked up, but I took the 4 minutes to relax. Can you pick that up? Are we that close? Can you pick up how relaxed I am now?
Yeah, what you didn't do, though.
Oh, what didn't I do? Don't get me worked up.
Well, you were talking about arcades and everything. See,
yeah.
You had to start us there. You're going to have to shift your pizza buying habits.
Why?
You don't know about the difference between Papa John's and the Pizza Hut?
No, what's the difference?
Well, you know, Papa John's was the official, Sam, you know this? What was it?
They were the official sponsor of the NFL.
And?
Now they're not.
And why are they not?
Because of the whole taking a knee.
Because the president of the CEO, the guy on the TV, ate the NFL out bad about the knee thing. He said, look, this ain't right. So the NFL's kicking him out, and they're going over to Pizza Hut.
Yeah.
So anyway, we got to stick with Papa John's. It's like when they
You're
had
not
that.
allowed to eat Pizza Hut anymore.
No more Pizza Hut. It's like when they. They boycotted. Like remember now when they boycotted the Chick-fil-A in New York.
Right.
Opened up the Chick-fil-A and all the left. Sam, you're not listening. When they boycotted the Chick-fil-A in New York, they were backed up blocks, people standing in line to get in Chick-fil-A and buy Chick-fil-A, protesting all those goody two-shoes. So,
well, there's two things I don't want to gloss over. First of all, you need to know Rick's the troublemaker. It's not Sam. So if Sam's not listening, it's Rick's fault. But we just wanted to say that, right?
Yeah,
but I don't want to gloss. Rick's like, how did I get in trouble? What'd I do? Rick did have valid. So here's the thing I don't want to gloss over. Oh, wait a minute. Did you send her all the answers? Because you guys you're always saying Sam.
No, because she keeps up. And Rachel Dolezal's gone on food stamps.
Oh, that is the white black lady.
Yeah.
Yeah.
Now, I want you to just
took me a minute.
I want you to think through this.
Elaborate on that.
Okay, I want you to think through this a little bit.
Well, what did I get wrong? What did I say?
2 years ago, this white woman who said she was black and had her hair all frizzed up was the CEO of the NAACP.
Right.
And they fired her because she was born white to white parents. Well, now today, they've already told you when you go to kindergarten, you can tell them that you're a boy if you're a girl. You can tell them you're black if you're white. So they really should never have fired that lady 2 years ago. If now you can just say you're black, then you can be the head of the NAACP.
Yeah, she should be.
I wish we would go back to the years when options were power windows or roll them up.
Yeah, right.
Kind of like when
not your gender in kindergarten.
It's like when Jay Leno got fired for saying he wouldn't support Obama. Right. Now he should be reinstated because everyone bashes Trump.
Anyway, so she's
whoa!
She's
this is Ask the Doc. The all-star political battle comes up next.
Okay, all right, let's go ahead. So
you got them all involved.
I know,
but you did a great job.
I know, but you always say you got to start with something that's fresh. And I was trying to give you your quiz. You said the other day, I got to go home and study because Dr. Whaley's going to ask me a question. Well, so I'm asking you a question about the news now. And Sam and Amanda got the answers right. Okay, let's go.
All right, now you're going to have to, let's start with our first question.
All right.
And you're going to have to pronounce these so I don't get them wrong. What is the difference between
sarcoma
and
carcinoma?
Folks, what is the difference of sarcoma and carcinoma?
Well, first of all, I mean, I really don't want to make light of it, but let's make light of it. Who really cares? Both of them are malignant. Both of them can vary between very indolent and mild cases on the one hand, very rapidly progressive and fatal cases on the other. But it's sort of like the difference between an automobile, a car, and a pickup truck. This past year, they sold more pickup trucks as primary vehicles for families than they sold cars. But they both get you from point A to point B. You got that picture up there for me? All right. This picture, which nobody's going to be able to read the numbers, shows a outline of a body with different size circles pointing to different types of tissue that are involved in, quote, sarcoma. Now, you can remember back in your high school biology that the body, the body has what we call mesenchymal tissues. That's like muscles and stuff, and then epithelial and endothelial tissues. So sarcomas are generally muscle, fat, called liposarcoma. The tumor of kids, osteogenic sarcoma, like the Kennedy kid had and lost his leg and all that. So sarcomas are particular tumors of the tissues that make up let's say the skeleton. And carcinomas are virtually everything else. Show up that big picture there. Sometimes people, you know, they get scared to death. They go to see the dermatologist, and he does the first the little hot cold thing, and he says, I don't need to worry about this one, this one, this one, this one. He freezes them and they fall off. But then he says, wait a minute, I'm going to worry about this one. He takes a little scrape of it, and then he calls you back and he says, you've got a basal cell sarcoma, a basal cell carcinoma, or you've got a squamous cell carcinoma on your cheek. You need to come back in, and we need to take it. So those are minor skin malignancies, but they are carcinomas. Now, somebody comes in and they've got ovarian cancer on the list there. It starts at bladder, brain, breast, cervix, and goes all the way down to prostate. But virtually all of the cancers that you think of are also carcinomas. So they're malignancies, different origins of the tissue in the egg in the developing egg and fetus, and that's really just a term for pathology. We're making a lot more progress in all of the carcinomas because we know what the genetic changes are that drive them. We're learning less about the sarcomas, but the sarcomas are a tiny group of tumors compared to the carcinomas. Is that good enough, guys? Okay, I didn't want to, because it could get really complicated if I got much farther than that.
Okay, let's go.
Is that far enough?
That's far enough.
All right, go ahead.
I think this is one, I'm really interested in this question because can nutrition help battle cancer or improve a cancer patient's quality of life?
Yes. Okay, and the next one? We've gone through this several times in the past. If you just take two groups of people with cancer that is advanced to the point where you're having to treat them with chemotherapy or radiation, versus a patient who has a lumpectomy, they get their surgery, they take a little bit of chemo, they take radiation, and they end. If you're focusing where the nutrition is the most valuable, it's on the patient with advanced malignancy getting very heavy treatment. If you take those two groups of people, and we'll do the easy thing first, and one group exercises and the other group doesn't exercise, you don't really have to be a rocket scientist to think that the one that's going to exercise is going to do better than the one that doesn't. Is there any really good reason for that now when they got the same stage of cancer taking the same treatment? Yes. The one who exercises is going to have more lung capacity if he gets pneumonia. He's going to have better fitness if he gets a blood clot. So the exercise improves your ability to take the hits that you get from cancer therapy. Now, from nutrition. Soon as somebody starts thinking about cancer, they start getting on the internet, or their aunt in Idaho or somewhere start sending them all this stuff, and it says broccoli and Brussels sprouts are anti-cancer drugs, and sugar feeds cancer, and bunches of myths of that sort. So the cancer patient quits eating much in the way of calories and starts eating spinach and things when he really needs a whole bunch of calories. So once we have somebody on advanced cancer treatment, we immediately have we're the fifth biggest cancer group in America. We got 25 nutritionists, and they have this video thing like this where they talk to the nutritionist. We get them immediately into the nutritionist. They need protein, and that protein helps them fight low blood counts and infection, and they need calories. I had a patient yesterday who keeps eating healthy, and I told the lady that brought him in, I said, I want you to take him down to that barbecue place in Ellijay, because he can get pecan pie with ice cream and French fries and a big old barbecue sandwich, and he wants to go out there and eat celery and stuff. So the answer is yes. Quality of life is much improved if you exercise, eat a diet that's got good protein to it, and got plenty of calories, and the outcome is better. There.
Okay.
And taking a bunch of vitamins doesn't help.
Well, thank you for throwing that in. No, I'm serious, because
2.5 miles on a treadmill. What you're saying?
Yeah.
I prescribe that. I say, look, start. And by the way, I was getting ready to tell you, don't push it too fast, because you're giving enthusiasm for your progress. And I mentioned to you a few weeks ago, if you raise that product by more than 10% a week, 2 months from now, you may have a stress fracture or bad tendon, and you say, wait a minute, I haven't changed much. So don't push it too fast. But that 2.5 miles on a treadmill 3 days a week, if I was treating you for malignancy, I'd give you a gold star every time.
Got a gold star
every time.
That you just all
right. I mean,
they did not want me getting a gold star.
He doesn't get many
there.
Gold stars. Okay,
but I got one.
Oh my.
All right.
Okay, is there a recommended regular cancer screen? If so, how often should a person in their 30s and 40s, like myself, get one done? Is there a regular recommended cancer screen, and how often when you're in your 30s
Okay,
and
well,
40s?
this is such a complicated question. We talked about this a few weeks ago. We were talking about what Medicare will pay for and Medicare won't pay for, and then what various advocacy groups recommend. For example, I mentioned that the American College of Dermatology wants you to get a total body skin screen in your 20s, and you know, there's a lot of difference between what advocacy groups recommend and what insurance and Medicare will pay for. So the question's got two sides to it. So sort of the very conservative, tree-hugging insurance, Medicare, Obamacare recommendations. All right, so this would be considered the minimum recommendations. Okay. I think that's worth putting it that way.
Okay, and I'm okay with it. I'm absolutely fine.
And when we run out of things to do, I'm going to talk about stuff that's popular in medicine. I'm going to talk about stem cells at the end, where it's totally junk, and people are out there trying to make money. All right, now, so in Sam's age group, between the ages of 20 and 29, we're going to start with adults. All of the recommendations regarding adults are basically about history. So you're going to want to know about the family history of colon cancer, breast cancer, and ovarian cancer. You're going to want to know about the sexual history of females because of the HPV and cervix cancer, and you want to ask that female, she's 22, 25 years old, and the male, did you get the HPV vaccine? And if they say no, then you go on and recommend that they get the vaccine. So in terms of what would be recommended and basically sort of paid for in a wellness exam, that's all history except the HPV vaccine for the adolescent who didn't get it by the time they're in their 20s. The dermatologist would tell you you need to have a total body skin inspection, and if you're at your private practitioner's office, let's say you're at a GYN office getting that history, you really would hope that they take your clothes off and look to where the sun doesn't shine. So now let's go to the next group. I think they asked about 30 to 39 and then 40 to 50. So 30 to 39, Sam, you got to listen to this because it's going to focus on women. 30 to 39 is the exact same history for the men, family history, colon cancer, prostate cancer, all still history, no physical exam. You don't take off your clothes, but in women here, you're going to emphasize that women need to know what their breasts look like and feel like under normal conditions, so that if they have a change in one breast that's not on the other side, they'll recognize it. So you learn about breast self-examination, and at that age group, they will have a breast exam by somebody who knows how to do it. And that then would be a gynecologist or a primary care physician that has an emphasis on it. This is the time when they will begin having a pap smear, They can do it at every 5 years if they have had HPV testing, every 3 years if they have not. But that's the only test, Pap smear in females, that's recommended below the age of 39. So when you now we're asking the question about 40 to 49, so that's the next decade. So now we're going to go back to the history of, did your dad have prostate cancer? Now we're going to focus a little bit more on men. If you are an African American male, then at this age group, you're going to have your first PSA, you're going to have a digital rectal exam, and if you're a white male or a non-African American male, and at least 2 family members at any generation have had prostate cancer, you're going to get your first PSA, and you're going to get a digital rectal exam. Now that female, again, is going to get her breast exam. She's going to be doing it herself. And if there's a family history of cancer of the breast, where several family members have had either breast or ovarian cancer, you'll get your first mammogram in that decade of 30 to 39. Once you've hit 40 to 49, women are going to get their first mammogram at age 45. The recommendation of the diagnostic radiologist is annual mammograms after 45. Recommendations of the people who pay for it sometimes are every 2 years after age 45. I recommend every year after age 45. But if you had a positive family history of a lot of breast cancers, we gave you that first one, remember, at 35 or 40. So after 45, they start doing that. We still got to stick with the Pap smears for these women who are sexually active at every 3 to 5 years. Once you get to 50, now everybody in here except for these young women at the bar are over 50. Colonoscopy at age 50 is the age at which we should do it. If you've got that strong family history of colon cancer, which I was talking about before, you may be getting your first colonoscopy at age 40 to 49, like the women with the breast cancer history got their first mammogram at the age of 30 to 39. At age 65, talk about what does Medicare pay for. At age 65, Medicare will pay for mammograms, Medicare will pay for colonoscopy, Medicare will pay for Pap smears every 5 years. So now you've gotten to the point about what kind of cancer screen will somebody pay for. And below the age of 65 in Medicare, it becomes a battle of what kind of insurance do you have. So is that
yes, it
comprehensive
is.
enough?
That was very good. That was comprehensive enough, and it did explain, 20 to 29, 29 to 30, and then 30 to 40 got into my age group there, and then you
just remember
50 and above.
Yeah,
something to look forward to.
Just remember when you turn 50.
Okay.
You got to get a colonoscopy at 50. You got to get the PSA at 50, regardless of what the Medicare people and this stuff say about not wanting to pay for it. And you've got to let somebody examine you and actually put their finger on your prostate when you're 50. And girls, you got to let somebody put their hands on your breast in the 20s and teach you how to do it in your 20s. And it's just got to be done. Somebody's got to examine you.
I have a question, Dr.
Sure.
Lilly. I've actually had a few family members and a few friends get breast cancer between the ages of 20 to 30.
Yes.
Why don't insurances push for that age range?
Because the incidence is so small that the cost benefit in terms of dollars per case found is above what they're willing to pay. And then the argument used to be that the amount of radiation you would start getting if you did it in your 20s and did it annually to the breast begins to exceed the amount of radiation that you want to be getting that you don't have to have.
Right.
And so I'm going to give you what they're going to tell you, although I don't agree with all of it. Oh, and lastly, between the ages of 50 and 59, let's talk about people who might have smoked. Sam, when I say that you've smoked X number of pack years, do you have that in your head? Pack years. Okay, so if you smoke a half a pack a day for 30 years, you've smoked 15 pack years. If you smoke 2 packs a day for 15 years, you've smoked 30 pack years. So that number of 30 is the age, it is the accumulated amount of smoking that makes it suggested that you get what's called a low-dose CAT scan of your chest for early detection of lung cancer. Now, regular insurance, many of the regular insurance plans that emphasize prevention actually pay for that. So if you buy history and you smoked when you were younger and you add the number of years in the packs per day and it gets to 30, then at about age 50 they'll start doing that CT scan of your chest for you, and that is a paid for thing and is recommended. So I'll throw that out there for the people who might have smoked.
I want to double down on that next week. I want to get to this last question in our All-Star panel, but I do want to double down on that next week because I want to go a little further into that. Why is gallbladder removal the automatic prescription when gallstones are found? Are there any alternatives? So gallstones, and the doctor comes in and says, hey, we got to take your gallbladder out next Tuesday at 2 o'clock. Why is that immediately the decision?
Okay, well,
is there any other alternative?
Yeah, well, I've been doing this program for a lot of years, and so I've got this, and the radio program, and I've got a favorite saying that I've used many times. And Sam, that statement is, to a hammer, everything is a nail. Okay.
Well, you were on a roll today.
I had no idea where he was going with that.
All right. So now, and then the other one is, if it ain't broke,
don't fix it.
All right, so everybody's heard both of those. The presence of gallstones does not mandate any therapy. The presence of gallstones does not mandate any therapy. So quite frequently, people will go and they'll have some sort of an x-ray of the chest because they fell and they broke a rib, and they'll say, oh, and you've got gallstones. Or they'll have a kidney stone and they do it in an ultrasound and they say, well, you got a kidney stone, you passed it, you got gallstones. Okay, that patient with asymptomatic gallstones should be left alone. That's number one. Second, you've got a patient who has got acute abdominal pain, they go to the ER, they ultrasound them, the thing gets better. First attack of gallstones generally is observed and not treated by surgery. Now, when the patient comes in and they're yellow as a gourd, they got an acute abdominal pain and a high white blood cell count, and they got gallstones, you've now reached the emergency situation where you got an obstruction, you got an infection, and that group of people has to be treated in some fashion to remove it. So the question was, are there options? Yes. First of all, just because they're there, don't take it out. Second, most people who have a first attack of gallstones are told to watch it. You may never have another. 30 to 50% never have a second episode, so why take out the gallbladder? 30 to 50% never have a second episode means that 50 to 70% have a second episode. And in that situation, laparoscopic gallbladder surgery is the treatment of choice. 750,000 of those operations are done in the United States every year. They're extremely safe. You go in a hospital, you're out by 4 in the afternoon, and you drive, you go to work the next day. When I was in training, they made a slice that long into your rib cage, you're in the hospital for a week. So that operation is safe, it's done by somebody who knows what they're doing, and 750,000 of them are done a year. In terms of options to that, when you have only one stone and it's lodged down in the bottom of the bile duct, there endoscopic retrograde cholangiopancreatography, otherwise called ERCP, where they look in there and they take a little thing and they open up the tube and it falls out. That's a non-operative option. You don't see it very often. Everybody will say, well, wait a minute, my brother had big kidney stones and they broke them up with a shock wave and he passed them. Can you break up these things with shock wave? And the answer is essentially no, but a couple of times in the world it's been done. And last of all, there's a pill called Actigall, Actigall, that you can take if it's a cholesterol stone, and you may have to take it for 1 to 3 years, and it can dissolve the stone. It can't dissolve any with calcium in it, and it can't dissolve any stone that's not cholesterol, and most of them are cholesterol, and it's not very often used. There.
Okay, so now I have a question for you.
Yeah.
You're always giving everybody else a test.
All right.
Now here's your test.
Okay.
So I no longer have a gallbladder. It's gone.
Right. Okay, good.
All right. So I had a couple episodes. All right.
Yes.
So finally the decision was made. It had to go out. So I sit down with the doctor, and the doctor said, "Okay, Tuesday at 10 o'clock, we're going to take the gallbladder out." I said, "No, we're not doing it Tuesday at 10 o'clock." He said, "Yes, we do it Tuesday at 10 o'clock. That's the day I come in to do it." I said, "No, we do it on Friday." He said, "I do not do gallbladder surgeries on Friday." I said, "You'll do this one on Friday." Okay? So he took my gallbladder out on Friday. Why did I insist on my gallbladder being taken out on Friday?
Because you wouldn't have to go on TV the next morning.
No. Because if he did it on Tuesday, I'd miss 2 days' work. On Friday at 2 o'clock, I could work early in the morning. I'd go into the office, see what's going on, run over to the hospital, get the gallbladder back, be back by Monday.
That's what I did with my cataracts.
That's why I did it. Yeah.
That's how I did my cataracts.
You don't believe that? That's a true story.
And do you want to know why?
We work with you every day. Yes, we do.
No, lots
And
of
do you want to know?
doctors actually do prefer to do surgeries on Fridays now, I've noticed, because of work schedule.
Do you want to know why he doesn't want to do it on Friday?
No, why?
Because
That was 19.
no,
That was 1998. He's got a golf.
No.
You stay out of this. What?
he doesn't want to do it on Friday because if there's a complication and you have to spend the night or he has to come back in, that means he's got to go to the hospital on Saturday morning and let you out. And
Okay, I see
he
that.
doesn't want to do that on the weekend. So if he does it during the week, well, seriously, on Friday, he's available for anybody on Wednesday and Thursday that had a problem, but he'll use that day in his office to see new patients to schedule for surgery the next Monday, Tuesday, Wednesday, and Thursday.
1997, I went in the office that morning. I checked to make sure everything was going okay. I left at 10 o'clock. I went over to Baptist Hospital in Winston-Salem, North Carolina. Went into Baptist Hospital there in Winston-Salem, North Carolina about 10:30. Got prepped, had the gallbladder out at 2, went home at 4:30. Relaxed over the weekend, played golf that Monday right after I showed up for work. Got it? What do you want to close with?
I think.
Like a superhero cake?
Did you hear that? Did you hear that, Dr. Whaley?
I gave him a gold star earlier. He's taken it to it. He's gone to his head.
Dr. Whaley, it's gone.
Okay, I really want to make a point out of this because I've had this question asked by people that are very dear to me. Wednesday at the American Academy of Orthopedics, a signature study was presented about stem cell injections into joints. And you've got people that all around here that talk about the stem cell center. In the United States today, 600 for-profit places are doing, quote, same-day stem cell injections for knees, hips, or other joints, and they are touting success of 80 to 100% in helping pain and relieving joints and so forth. First of all, there is not one scintilla of evidence, of scientific evidence, that the stem cell taking from your fat or your peripheral blood, spun down and injected into the joint, helps anything. And the price that they charge is $2,000 to $12,000, depending on where you are. No insurance pays for it, and it's the largest new profit center for orthopedics, rheumatologists, and people with no joint training whatsoever. And they're putting up these centers, and they're not regulated by the FDA. They're not regulated. They don't have any regulation. And so they're putting them up, and they're telling you that if they take this out of your fat, that they can make your knee be better, or that they can put stem cells underneath your eye and make these little bags go away, or they can put them over here and tighten up your chin. And the stem cells are the cure for multiple myeloma after chemotherapy. The first patient in the world to ever get a stem cell transplant for sickle cell disease got it last week. And so that's a totally different thing. It costs hundreds of thousands of dollars. and you'll see that stem cells are doing all of this magic stuff, and it's really technical, and it's in a small number of places. Well, people just leaped all over that, and they're making money hand over fist, and it's a total scam. So when the American Academy of Orthopedics, and a lot of the people that are doing that, orthopods, comes out and has this whole great big seminar on it, it's sort of like the Oracle at Delphi saying, guys, your behavior needs to change down here because this isn't right. So I just don't want anybody going out there getting stem cell injections this afternoon and thinking they're going to get well, and that's a scam everybody needs to know about.
Thank you, Dr. Whaley. I appreciate it. We also appreciate Georgia Cancer Specialist Northside Hospital Cancer Institute for sponsoring this segment, Ask the Doc with Dr. William Whaley. If you have a question that you would like to get to the doc and have answered on our show on Friday, you send that to info, I-N-F-O, at FetcherNews.com, info at FetcherNews.com. Put in the subject there, Ask the Doc. We'll get that to Dr. Whaley throughout the week and try to get an answer on the show. And yes, if you need surgery, schedule it at 2 on Friday afternoon so you can be back to work Monday. And I am the greatest boss in the world, and I know why. I have the cup that says greatest boss in the world, right?
And he got a gold star for the 2.5 miles.
Ask the Doc, all-star panel right after this. Unemployment, 4%. Who would have thought? Take a break.